Neuron.
What do you know about the neuron? It says impulse and dose system. Receives. All right. What are these dendrites? What do the dendrites do? They're the receiving end. Okay. So once we get our message in the dendrites, it moves into the cell body and the axon. What does the axon do? Right, it converts whatever signal we get into an action potential. And it goes down here through these myelin sheaths. Now, not all neurons have myelin sheaths. If they do, what does the myelin sheath do? It protects it. What else does it do? It speeds it up. It makes it go faster. Which is why in the spring, when you guys start to learn about like Alzheimer's disease and a lot of the neurocognitive disorders, one of the biggest things with it is that these myelin sheath degenerates. So the signal can get through faster. Okay. So it goes from just like a normal signal, right? Our neurotransmitters then turn into an action potential, goes through here. It comes out to the synaptic terminals. These connect to these. This is how we pass messages along. Now, I believe I left it in the notes section of your PowerPoint, there is a video that I watched, like the whole thing, and actually like how he explained it. It actually helped me understand it a little bit better. Okay. So, this is your synaptic club, right? This is where they connect. So what happens once we get toward these synaptic terminals is they enter, but like our neurotransmitters enter these like vesicles that bring it to the very edge where like pushes it out. Then on the dendrite of the next neuron, there are receptors. Whatever neurotransmitter does not connect to these receptors either just dissipates or it gets returned. Sorry, I'm not even going to have something. Gets returned into the last axon nerve. So that's when you guys get to second next semester, you learn about serotonin reuptake inhibitors. So it prevents that reuptake of whatever the serotonin. Or you can have drugs that promote that reuptake to increase our levels of serotonin or whatever neurotransmitter. It's either destroyed or it's reabsorbed. So, we'll talk about neurotransmitters. What does it mean when a neurotransmitter is excitatory? It promotes it. Whatever the neurotransmitter does, it promotes it in the next neuron. And if it's inhibitory, slows down. So, let's talk about acetylcholine first. So, it comes from our autonomic nervous system and parasympathetic effects. This is your cholinergic system, right? You guys remember that? I think in biology or human anatomy, one of the two. The primary functions is memory, learning, motivation, and attention. But really what it does is this one, muscle contractions. It processes your heart rate, your blood pressure, respiratory rate, digestion, also sexual arousal. It does promote REM sleep. So again, when you guys get to next semester, you're learning about Alzheimer's disease, and you hear something called anticholinergic, where anti-acetylcholine. Does that make sense? So this helps increase my blood pressure, heart rate, all that fun stuff, the anticholinergic. So yeah. Whenever you see the parasympathetic nervous system, acetylcholine. Serotonin. I'm sure everybody loves this one. Fun fact about serotonin. Yes, it comes from the brainstem, hypothalamus, dorsal horn of the spinal cord, but 90% of it actually comes from our guts. Which is why a lot of times people with anxiety and depression, they have a lot of belly issues, right? I like to say hot girls have belly issues. Emotions, mood, sleep, it inhibits pain pathways. GI homeostasis, right? Because 90% of it comes from our guts. Pupil dilation, sexual pleasure, addiction, and stress. We're going to talk about that in a second. Wound healing and clotting, it actually can come off platelets, which is why it's called wound healing, and bone health. This is your feel-good hormone. A lot of times you see that attached to dopamine, but really it's this one. Dopamine is your pleasure center. We're going to talk about it in a second. It works with melatonin in order to help you fall asleep. So if I don't have melatonin, I'm not going to have great serotonin. It also leads to anger, aggression, labile moods. It is found in salmon, eggs, cheese, turkey, tofu, pineapples, nuts, oats, seeds. I don't know where I'm going with that. I just kept on using it. Sometimes I start a sentence and I don't know where. All right, dopamine. Dopamine is your reward center. This is important in diseases like ADHD, drug use, alcohol use. It controls fine motor movement. It also does mood and sleep, but it's not going to make you angry or aggressive like serotonin will. If I have low, that's when I have that lack of motivation or really want to do anything or dragging throughout my day. But if I have high dopamine, that's when we have manic episodes. We increase this with L-tyrosine foods like bananas, avocados, exercise. So what's the biggest difference between dopamine and serotonin? I'm not gonna lie to you guys. I looked that up last night because I was going through these slides and I was like, really, what is the difference? Because if I have dopamine and I get rewarded, I feel good, feel the hormone. But that's serotonin. So the biggest difference between the two, where serotonin is found mostly in the gut, dopamine is mostly in the brain. We do have a little bit of dopamine in our guts, but not anything like serotonin. If dopamine causes hunger, because we want that reward of having food, our serotonin is what suppresses the appetite, so that we don't feel gross after eating McDonald's at 2 o'clock in the morning. Not that I've done that recently. Dopamine is your temporary pleasure, where serotonin helps you have that long sense of happiness. That's the main difference. Okay, norepinephrine. I'm not going to go too in-depth about norepinephrine and epinephrine, because we are going to talk about that a lot in endocrine, but I do want to touch on it because it's both a neurotransmitter and a hormone. Norepinephrine is made from dopamine. It controls your mood, increases alertness, attention, and it's based on sugar. This is your fight or flight neurotransmitter. I know you guys haven't had anything yet, but where does our epinephrine or norepinephrine come from? The adrenal glands. Perfect. Where acetylcholine, we think parasympathetic nervous system, norepinephrine, epinephrine, think sympathetic, fight or flight. This is promoting our vigilance. GABA. One of those that I feel like is kind of forgotten about a lot of the time. So GABA, it comes from nerve terminals in our spinal cord, cerebellum, and basal ganglia. This calms the firing nerves in the central nervous system. So we're actually blocking signals and slowing down the brain. Think of your GABA like the brakes. You're pumping the brakes on your signals. It reduces stress and anxiety. Why? Because we're stopping all those signals from firing a little too fast. It improves sleep, again, because we're slowing our brains down. It's an amino acid. We actually find it a lot in tomatoes, which is actually a good thing because I believe it's the Mediterranean diet is very high in like tomatoes, cucumbers, red onion, like that. Anyway, so they have high levels of insulin, right? That's why in that area, people who have, take on that diet have less chance of getting that stress. It binds specifically to those receptors in the synapse to block these signals. It's literally the brain. It's like your emergency brake. We're going to talk about glutamate in a minute, but GABA is the opposite of glutamate, but it also comes from glutamate, right? It's like when you calm yourself, but it's like an evil whip. It's a very delicate balance. So glutamate comes just from the spinal cord. It functions mostly in your learning, memory, cognition. Important role of glutamate action potential. So if GABA is my brakes, glutamate is my gas pedal. It's also an amino acid, just like GABA is. This one is essential for brain function. It's also found in tomatoes. It's also found in MSG. So have that Chinese food in your order. It interacts with 4 different receptors, which is why it helps process information on the clock. Say that last time. in dark chocolate and spicy foods. So I eat a lot of dark chocolate, just because it's just right. It's released during sex, exercise, and eating, or when you laugh. So if you're feeling down, just randomly laugh it out. And it also regulates your appetite. All right. So, what is your central nervous system? What are the two main components? Brain and spinal cord. Let's talk about the brain first. Woo! All right. So you have three main areas, right? You have your cerebellum, cerebrum, and your brainstem. We have two hemispheres in our cerebrum: a thalamus, hypothalamus. Hypothalamus below the thalamus. Our brainstem is our midbrain pons and medulla. You have some water point, we're going to talk about that. Diary. These are the wrinkles. Essentially, all that does is increase the surface area of your brain to help move things along faster. The outside of the brain is your gray matter. What is gray matter? Do we know? Yeah. It's the cell bodies of your neurons. The white matter is those myelinated nerve endings. So we go from the tippy top, that's your gray matter, and then that myelin sheath where that potential action lives, that's your white matter. We're not going to go there. I'm not going to ask you a question on the example. Which section is the white versus gray matter? That's a little too in depth. So, brain lobes. I actually printed this out for you guys, that's why I ran away. Because I think it's hard to, see it on your little sheets. So, different lobes do different things, right? Frontal, this is your executive function. What is it function? Your problem solving, your personality, your behavior, your moods. When we talk about TBIs, strokes, so if I have ischemia and damage to this frontal lobe, I'm going to have issues with my personality. I'm going to have issues planning, organizing. Inside of the frontal lobe is your Broca area. What is Broca? Speech. Expressive speech, to be exact. Speech is typically found, the speech centers are found mostly on the left side of the brain. So, Broca, if it's damaged, stays broken. I can't express what I want. Now, your parietal lobe. Parietal. It's a sensitive lobe. Your sensation, right? This is why I picked this, because it gives you like a little bit of piranha bites. Bites are sensitive. Your parietal lobe is your sensation lobe. It also works with your body awareness, your attention, how you do math. It also processes temperature, pressure, touch, smell, and taste. Occipital, this little guy all the way in the back. Occipital optic, so those are your visual. Again, when we talk about stroke, we're going to talk about that a little bit more. And then your Wernicke area is within your temporal area. So temporal, big tempo. Hearing. It does also work with hearing and attention, but Wernicke's area, receptive speech. So where frontal is expressive, I can't confront you. Temporal, I can't think about what you're saying. Again, usually these speech centers are on the left side of the brain. If I have a left side stroke, that's when I'm going to have issues with my Broca and my area. We're going to talk about the brainstem and cerebellum in a minute. But your cerebellum is your main brain. This is your balance, your coordination. In your brainstem, that's your consciousness, your breathing. We're going to talk about that. What's questions about that? You fully form this at 4 years old, which is why so much learning and development happens in the first 4 years. But we actually continue to grow this just more slowly until we're in our third decade of life. I'm not teaching myself. All right. Cranial nerves 1 and 2 live in the corpus callosum. We can do, I forget the actual term, but we can cut this. Without cutting all the brain, we can just cut the corpus callosum in half. And what we do that for is a type of epilepsy, which we're going to talk about seizures in a little bit, but specifically for atonic seizures. Because essentially all you're doing is you're cutting that connection of your left and right. So you're preventing the seizure or the hyperactive brain activity from going to the next part of the brain. Not of the brain. But if I cut this, I lose my balance. I can have aphasia. I run the risk of strokes. Or I can have something called hydrocephalus, which is when water accumulates in the brain. Alright, let's talk about the thalamus and hypothalamus for a quick second. So, in terms of neuro, the thalamus is your relay station for all sensations except for your smell. Why? I have no idea. Your pain impulses passes through your thalamus. Your hypothalamus is what actually connects your pituitary gland and regulates hormone secretion. Again, we're not going to go way too in depth about that, but it's a good little precursor to when you get to endocrine. Your hypothalamus is like your hunger, appetite control. Again, for neuro, your hypothalamus, that's what really runs our automatic nervous system. It regulates it. And you're going to see the term basal ganglia a lot. When I tell you, I tried to find a diagram for like a solid hour of like where exactly the basal ganglia is, and I could not really find it. But really what we need to know is that that controls your fine motor movement. My general rule of thumb is that if I can't find something to help you guys learn it, I'm not going to test you. Alright. Questions so far? Am I going too fast?
Yeah.
I have to get to that.
Sorry, can you just say that last part? Your basal ganglia controls your what?
Fine movement.
Fine. Thank you.
I do have a question.
Yes.
As far as testing goes, I know we're kind of concentrating more on the nursing process.
Yes.
So how are these like anatomy things going to relate?
So my biggest thing is whenever I review anatomy with you guys, it's because my questions are, if you know the basic anatomy, it helps you think through the question, right? So if I ask you a question of, let's just say point blank, somebody's had a stroke on the left side and they're having receptive aphasia, what lobe was damaged? That's kind of my thought process there. I also think that by going over the anatomy, it helps you walk down the road, especially when we get to the spring, because that's when we don't go over anatomy anymore. So I do it a lot because I think it helps you think through a lot of the diagnoses. And that's also just how my brain works. Like if I can understand the anatomy, the diagnosis, I don't have to study as hard. Right? Instead of learning a diagnosis to anatomy, I like to learn anatomy to diagnoses. moving information to your body. This helps with peace, touch, but it's really mostly important with respiration. Cranial nerves 5 through 8 live in the pons. I'm not going to ask you guys about cranial nerves, but again, your inflex might clear down the road. That's why I'm going over. 5 through 8. Your medulla oblongata contains motor fibers. It brings the motor fibers to the spinal cord and sensory fibers to the spinal cord. I'm sorry. Motor fibers from the brain to the spinal cord. Sensory fibers from the spinal cord to the brain. Motor to the spine. Sensory to the brain. This is what actually connects your brain and your spinal cord together. Cranial nerves 9 through 12, starting this bad boy. It is your center for breathing, blood pressure, heart rate, coughing, vomiting, sneezing. If I damage my medulla oblongata, that is life threatening. So, who here has seen Waterboy? Yeah, a lot of people. The movie explains that your medulla oblongata is too big if you're an angry person. That's not how that works. Your medulla oblongata controls how you breathe and how you react to anger, but it does not actually control your anger. Common misconception. Every time I hear the term medulla oblongata, I think of a Waterboy. And I have not seen it in probably 15 years. It also controls your reflexes and voluntary movements, but it does not actually control the rest of the behavior. It helps you regulate your breathing when you're angry. It's really all it does. And you're not angry. All right, my little brain. It integrates sensory information for smooth movement. So again, when we get to diseases like Parkinson's and all that stuff in the next semester, we're going to hear these terms again. It's not smooth movement in the cerebellum instead of tremors. It also controls your balance. It also lets you know the awareness of where your extremities are in relation to your body. So when you learn about Huntington's disease, you're going to learn about how that's really kind of damaged. It receives information from the sensory systems, spinal cord, other parts of the brain, and this is really where movement control happens. It might be little, but it's got a big part, right?
Are you talking about the brainstem or the cerebellum?
The cerebellum. Okay. Now, let's talk about the meninges for a minute. When I was building this structure, right, I know what Neuro or acronym or all that fun stuff is, but for some reason my brain did not connect with those with the meninges. Don't know why. But those are your meninges. So when we talk about meningitis, that's inflammation of these factors. Your meninges are fibrous connective tissue that covers your brain and your spinal cord. Right now I just have it pictured here. The dura is tough and thick, not elastic, and it's gray. When we talk about increased ICP, and there's too much pressure against that dura matter, it's not going to bend with the increasing pressure, so it's actually going to cause your brain to herniate down. Because it does not move. Your dura matter does not move. It is right up against that skull, and it's not going anywhere. Your arachnoid, that's your extremely thin and delicate layer. I have a picture of a brain coming up in the next section, but you'll see it's almost like a spider web. And right below your arachnoid matter is where your CSF lives, your cerebral spinal fluid. talk about CSF in a second. And your higher matter is thin and transparent, and it just comes to the brain closely. Questions so far? Say again? Yeah, they're cousin. It's a nice little bit. Because if you think about it, your higher matter is kind of like that last line of defense before infection gets to your brain.
So the, ICP, if you're to have that, it's through all the layers, but it sort of stops at Dura.
At Dura, yeah.
That's what causes the pressure.
That's what causes the herniation. And then it hits this last layer of the dura matter, and it can't go anywhere. So if I can't expand it up, I'm gonna get pushed. I'm gonna get pushed. Exactly. Yes.
Just an observation, I had somebody who filled their outfit for
Yeah.
twice. Ended up coming back and had a thorough hand.
Interesting. So I will say there's gonna be, well, we're gonna talk about like arteries and all that stuff, but this is just full of veins. Like that's that spider webby looking stuff, and we can get blood clots in the dura matter. And again, if I get blood clots here, and I can't expand against that or anything like that, herniation. So, we're gonna move into a little bit more about cerebral spinal fluid. It's formed in these ventricles. This was another thing that when I was reading, in my head I was like, okay, I know what ventricles are, but I don't know where they are. Like, have you ever seen a word when you're reading something, you're like, I think I know what that word means, but I'm not really sure. So I found a very nice picture. I'm not gonna test it on this stuff, but I think it's important just to see how they're all four are connected. And really, at the end of the day, this is where it's formed. So if I have a blockage here, I'm gonna back up here. And if I back up here, I'm putting pressure all in the slope, right? If I can't outflow my cerebral spinal fluid and it backs up, I'm gonna have increasing renal pressure. Yes. It's usually infection. It's usually infection or severe dehydration. So like it's not flowing enough. But most of the time it's infection. We can do a spinal tap to relieve the, sorry, here it's to relieve this flow. But at the end of the day, that's not gonna fix my production problem. But usually if I can relieve this flow and I push fluids, we can kind of fix this a little bit. We're gonna talk about ICP in a little bit and how to relieve some of that with like ICP monitoring. We're gonna talk more about it, but you are right. Like sometimes it just comes from infection. Sometimes it's a structural abnormality where this can't flow. It's called it's called the AVM. The AVM, arterial venous malformation, which is basically when they all clump together in the brain, and it pushes on the ventricles and it can't flow out, and you have to shut it. Alright, so cerebral spinal fluid is clear and colorless. But let's say someone is leaking a clear fluid from their nose and you get it on a gauze. What will it look like later on?
Yellow halo.
Like when it dries?
Like a yellow halo.
It'll have like that yellow ring around it. Yeah. It circulates the brain surface and the spinal cord. It's important in immune and metabolic function. We produce about 500 milliliters of CSF a day. Our ventricles and that subarachnoid space specifically hold like 100 to 125 ml. The rest is throughout the brain and in the spinal cord. So if you think about it, that's a lot of fluid, right? I want to say this is about 500 ml. It's strict copy, but it's about 500. Sometimes when we don't know what's going on with somebody, we get a tap and it says the cerebral spinal fluid, because that tells us sometimes too if there's just some sort of inflammation somewhere in the brain and spinal cord, if there's an infection. Sometimes it can be used to diagnose autoimmune, just in more of in the sense of it rules out a cerebral spinal fluid issue or a brain in more than 200 protein, then it's fungal. So right away, turbid means bacterial. I don't even think about the rest. And then I kind of go into these. I'm not going to test you specifically on this stuff. Your NCLEX. And when you get to the ATI, med surg, and the ATI predictor. It might just be one question, which is super annoying. But, not a lot of glucose in the cerebral spinal fluid, but it's good enough. It essentially kind of like matches your body. Just a little bit less. All right. Whew. Questions so far? Before we start talking about partners and shit. Okay. So, arteries. Arguably, the most important thing to know when we get to a speed insurance. Because if I know, like going back to your question about knowing anatomy, if I know, let's say, that I have a blockage in the middle cerebral artery, then I know all of these areas are being affected. So my question to you on the exam is, the MRI shows the blockage here. What symptoms am I expecting? Anything that relates to that is your answer, right? Instead of having to memorize just a middle cerebral artery stroke can have thousands of symptoms, I just need to know what these areas really are. I did create for you guys, I'm going to post it a little bit later today, because there's a couple of things I want to add to it. I created an entire study guide for you guys. Literally top to bottom, based on my slides, based on studying for my master's, a whole bunch of stuff. And one of the things, one of the activities I have in there is, like, draw the blockage here and color in where it affects and write the symptoms down. So I think that's going to help you guys kind of process it. And there's also like a little picture down here. So you can see the middle cerebral artery, affects that whole area. Right? That's your parietal lobe. Your posterior cerebral, a lot more of the occipital down here. And then your anterior cerebral, mostly, some parietal, mostly frontal. So if I have a blockage in my anterior cerebral artery, and I have a frontal lobe damage, what are some symptoms that you're expecting? Thinking, processing, personality issues. Your anterior brain, which is the front of your brain, is your common carotid artery. Your posterior, back of your brain, that's your vertebral and subclavian arteries. And your brainstem is mostly supplied, your brainstem is mostly supplied by the spacebar artery. We're going to talk about this little area in a second. It's called circle of Willis. Now, veins in the brain are a little bit different than veins in the rest of our body. The veins in our periphery have valves. And the reason for that is it helps push flow blood back to the heart. It's the opposite in the brain. We want veins to push back to the heart and not back to the brain, right? So you don't want to increase that blood flow. If I increase blood flow, I'm going to increase ICP. Are you following me? So, veins in the brain don't have those valves. We don't want to promote any type of backflow. We want to promote outflow. Does that make sense? Well, I don't need to talk about that. We'll do that later. So, your circle of Willis essentially is just a big fancy term for like the connection of all of the anterior and posterior arteries. But if I have a blockage here, I'm not connecting these two. If I have a blockage right here, I'm not connecting left and right. Your intracarotid arteries, huge. They supply 80% of your cerebrum. Which is why when we get to ischemic stroke, one of the tests that we do when someone's coming in for a stroke is we do a carotid ultrasound to see how blocked it is. Fun fact, my dad had a blockage in both of his internal carotid arteries. Literally, I think they were functioning at 20%. Who knows for sure? So, it's probably not. Connects bilateral posterior communicating arteries. Posterior cerebral arteries to create a communicating blood-brain barrier. Essentially, long story short, within your blood vessels, there's this very small cluster of endothelial cells within the capillaries. They're tight. They're tight, tight, tight. So those big molecules can't get through. Everything that goes through your CSF, including bacteria, has to pass through this blood-brain barrier. If it's lipid soluble, it can go through very easily. So think about like your lipid soluble vitamins, or when you're doing pharmacology and it's something says this is a lipid soluble medication, it's going to go through that blood-brain barrier very quickly. Things that can't get through, alcohol. Which is why if you drink too much, you throw up, because your body is saying, hey, I can't have this. I need to get it out of my body. It's toxic. Same thing with chemotherapy. That's why you throw it after chemo. Because your blood-brain barrier is saying, no, I can't let this through. I need to get it out. Okay. Technically, coffee can't get through. I don't know if you guys thought my throat can get through. Technically, Tylenol, Motrin can't get through. Benzodiazepines can't get through. What can? Or sorry. Sorry, alcohol, chemo, Tylenol, can get through, but it's seen as a toxin, that's why you throw it up. Sorry, I said that backwards.
Alcohol,
Can't get through.
chemo,
I'm sorry?
alcohol, chemo, Tylenol.
Yeah, all that
What,
was.
benzo?
Can get through, I'm sorry, can get through, I remember. But your brain sees it as a toxin, that's why you throw it up. What can't get through, or isn't supposed to, that's your viruses, your bacteria, the bigger molecules. If I have a brain cancer, or an infection, or a TBI, multiple concussions, that's gonna damage my blood-brain barrier, which is why you're more at risk for infections. And a bunch of other stuff. Outside blood-brain barrier, just outside of it, is your chemoreceptor trigger zone. That's when the chemo triggers your body. Your chemoreceptor trigger zone is just outside of the blood-brain barrier, and that's what actually triggers the body. Same thing with alcohol. That gets triggered. Does that make sense? Sorry for the backwards. Yes.
Is that because it did pass?
It's trying to pass
Okay.
it, but it still can pass. But it's kind of like your bad body's last attempt, because your body still sees it as something that, because really, you don't want stuff to get to your brain. You don't want alcohol to get to your brain. Even though we want it to, because we want it to work on our brains, our body's natural response is to not let it through. So that's that trigger zone. It's the body's last attempt to not let it through, but it still can. Does that make sense? Yes. I mean, that's not smart. No, I mean, like, I'm not in college, I mean, no comment. But, I mean, yes, but that's how you get alcohol poisoning. And that's why you have a lot of CNS symptoms with alcohol poisoning, because it fought through that blood-brain barrier and then it's talking about it. It's also why chronic alcoholics
discs can push on the spinal cord and cause a lot of sensory motor issues. We're going to talk about spinal cord injuries later. But fun fact, C1 and C2, there's no disc there. And then your sacral, so S1 to S5, and your occipital, there's no disc there either. Okay. So, big basic picture. What do you need to know about this? This is a picture that really describes the tracts of the spine. So you have your motor and your sensory tracts. Again, I was trying to think about a bunch of different ways on how to explain this to you guys, and I found it difficult. But I like how this video did it. The only thing I really care about is that when we talk about spinal cord injury, your anterior is for motor function. Your posterior is your sensory. Posterior is your sensory function pathways. Anterior is your motor. So if I have a spinal cord injury and I have it just like, let's say just this area is damaged, I might still be able to feel my periphery, but can't do this. Right? And there's still white and gray matter in our spinal cords. Okay. That's really all I care about that you guys know. Interior, motor, posterior, etc. When we talk about spinal cord injuries, it helps you understand what's going on. Okay? Now, either the person next to you or by yourself, I'm not gonna make you guys talk to each other at 8 o'clock in the morning. I just want you guys, of all the things we just talked about, come up with 3 things that you think are most important.
I was gonna say nothing for nothing. So the part of this that really stuck out to me was the different like hemispheres of the brain and how if one's damaged it'll have different effects on your personality or freaking your body's function. I think that was the most. Yeah. Yeah. Oh yeah.
Like the subject.
What?
I'm like the subject.
Oh, God.
The rest are both. So 5, 7, 9, and 10 are a mix. Because we can't just do that. So, like I was saying, your cerebral hemisphere contains 1 and 2. Midbrain, so this is going passing around. So, cranial nerve 1, your olfactory smell. How do I test that? You have the patient identify a scent with their eyes closed. Very easy. Number 2, your visual acuity field. So that's when you do your eye test with the doctor, or we don't like say how many fingers will hold up. Number 3, ocular motor. This is your eye movement, your pupil size, and how it reacts to light. So I test that by shining light on someone's eyes. I also test this by asking them to open and close their eyes. Back here. Trochlear. That's when you have them look down, up, side to side. Trigeminal. Chewing. Sensations of the neck and face. That's when you take like a little cotton ball, put it on their face, with their eyes closed, after you're putting the cotton ball. Your abductive, what is it when they're abductive? Got your lateral eye movement, so again, that's it.
Sorry, just a quick question. For the test, are we gonna need to know like the assessments or anything else?
For my test, no.
That's what.
ATI, NCLEX. Because I have access to like the ATI review modules, I do know that was one of the questions that was in there was, a nurse's assessing cranial nerve 6, which the question is the best way to assess that. I think it's cool, because I think your day-to-day life will, this is a very in-depth neuro assessment, so I think it's a cool test on cranial nerves, unless I'm a neuro ICU nurse. But ATI doesn't talk to me about that stuff. Alright, next one is facial. Face movement that takes on the front of your tongue, specifically the front of your tongue. Acoustic is hearing and balance from the vestibular and cochlear nerves in your ear. So if this one's busted, that's where you get the vertigo. Glossofacial
to cardiac, you'll hear beta blockers, called beta adrenergic blockers. So where my sympathetic system, my adrenergic system typically increases my heart rate, my beta blocker decreases it. Does that make sense? We have alpha, beta, and gamma adrenergic receptors everywhere in our body, which is why you'll hear the terms alpha 1, alpha 2 receptor blockers, or beta 1, beta 2 blockers. Not go too far. Sympathetic neurons live mostly in the thoracic and lumbar spine, and then parasympathetic mostly live in the brainstem and below L2. At the end of the day, just remember parasympathetic, cholinergic, rest digest. Sympathetic, adrenergic, fight or flight. When I was in nursing school, that's the only way to do this. So, I do think that this is important to know. So, if I'm talking specifically about my respiratory system, and I say, what are the parasympathetic effects of my bronchioles? Constricting, sympathetic, dilating. That sounds a little backwards, right? Rest and digest is relax, right? But when I dilate bronchioles, what's flowing to my bronchioles more? Blood, oxygen, just making increase my respiratory rates. I'm trying to move that oxygen. Sometimes these things sound backwards. You really have to think about what's going on in that body. So, parasympathetic, rate and force of heartbeat decreases. I'm trying to relax. I don't want to increase my metabolic demand while decreasing my rate and force of my heartbeat. Sympathetic muscle walls are more relaxed. But hey, rest and digest is parasympathetic. Why do I want to have relaxed muscles in my fight or flight mode? No more sense. If I gotta run away from some dude in the bushes, I need to have relaxed muscles so I can book it, right? Alright. Motor and sensory pathways. Everybody with me so far? Yeah. So, in our brains, there are actually like specific motor pathways that like neurosurgeons can go in and really tickle it. In like a wrist move or your foot and your ankle. Those are why sometimes you have to do major neurosurgery. Okay. So our motor pathways, that is our voluntary, involuntary movement, our coordination. Motor pathways come from the brain. Sensory goes to the brain. Right? Motor, away. Sensory. The most important thing with motor pathways for me is the upper and lower neurons. Because when we talk about spinal cord injury, it helps you understand it. And they do process in the medulla, so that's when we get that left controls right and right controls left, right? So, upper motor neurons. Those start in our cerebral cortex, cerebellum, brainstem. Descends down, right, lower down. Entirely in our central nervous system. If I don't have upper motor neurons, like if they're damaged or whatever, I can't do anything with lower. I need my upper motor neurons to regulate my lower. If I have damage here, this is when I become paralyzed. If I don't have upper motor neurons, I cannot stop involuntary movement, right? If I can't control everything underneath. So if I have damage to my upper motor neurons, that's when I still have deep tendon reflexes, those are involuntary, but they're hyperactive. I can't inhibit it at all. That is when I'm going to have severe leg spasms. Even if I'm paralyzed, I will still have leg spasms. My lower motor neurons
spasticity, some involuntary movement. I don't have any movement with lower. Does that make sense?
Still paralysis?
Still paralysis.
Okay.
But where upper motor paralysis, I'll still have spasms, like muscle spasms. I won't have that with lower motor paralysis.
So is like Parkinson's in relation to upper motor? Or,
Yeah,
or can lead
yeah,
to-
because upper motor starts with cerebellum, and that's where most of like those cognitive disorders start. Yes.
I'm so sorry. So you're basically saying if there's no upper motor neuron, you're gonna get the spasm technically, but it's not going to move.
Right.
And then if you have no lower,
Because I still have upper motor neurons, that will prevent that involuntary movement.
okay.
Does that make sense?
Yes, and if you have no lower, you're not gonna get the spasm at all. Okay.
So if I have somebody with upper motor neuron disease, I'm gonna wanna give them like a flexeril or a muscle relaxant. But somebody with lower, I'm not gonna need that.
Oh, got it.
Are there procedures that will permanently stop them from having spasms if they're not on
That's a great question. I actually don't know the answer, but I would assume yes. I assume that if I had damage to my upper motor neurons and my spasms were that horrible to my activities of daily living, I could probably have some sort of stimulator or some sort of surgery that can at that point just.
They have the box that goes in the brain and it controls it.
Yeah, there you go.
It's new.
So there is something in the brain that like, you, like.
It's like a pacemaker, but it's in the brain and it controls spasms.
Yeah. So, another thing to remember, so if I still have spasms, even though it's involuntary, my muscles are still moving a little bit, right? Lower, my muscles aren't moving at all. So I'm gonna have muscle atrophy here, not necessarily here. Does that make sense? There's still some kind of movement, it's involuntary, but it's movement. And I don't have any deep tendon reflexes here.
So the upper and deep tendon reflexes are present. but
And hyperactive.
Always hyperactive.
I won't say always, but most of the time.
But not present at all with just the lower.
Right. Because I still have involuntary movement here. I don't have any movement here. And it kind of sounds backwards because you think the higher up, the more damage. Because when you get spinal cord injury, that is true. But it depends. That's us. We're bodies. I love neuro. I really do. But learning it is tough. But I mean, you get a whole lot of good. Okay. Movement coordination. Depends on a lot of different things. Mostly the cerebellum. Because that's what contracts, that's what tells us to flex when we're hyperextended, so it's a bring it back, right? Your basal ganglia plan and coordinate motor movement and posture because it connects your cerebral cortex to stuff that are unwanted. You don't have this slide?
No.
You have this slide?
No.
Okay, ignore me then. I must have taken it out because I wasn't testing you on it. Okay.
Yeah, we got it right there.
We got it. You have this one? Okay. I probably took those out because I was going through it and I was like, this is more than I need to know. There was a certain point that I was going through it and I was like, I feel like I'm going, ooh, into it. Like I said, I'm a nerd. All right. Health history. So, we know our anatomy here. We're assessing our patients.
Bless you.
Bless you. I want to know what's going on right now. When did it start? How bad is it? Is it happening all over? Heart? Common symptoms of neurological disorders is pain, mostly headaches, seizures, dizziness and vertigo. Don't sleep on dizziness and vertigo, which is sometimes provided in visual disturbances, muscle weakness, abnormal sensations. I also know, what is your past history? When we talk about strokes, we're going to talk about CIA, right? I would want to know if somebody had CIA. I want to know if somebody in your family has had a history of seizures or brain tumors. What's your social history, right? What am I looking for in my social history? Drinks, alcohol, drugs. Maybe you hit your head recently because you were at a trampoline park. working at a media office could be our smart. Okay. Oh, don't do this to me now, what? Okay. So, 5 components. First, probably most importantly, consciousness and cognition. That is my mental status. Intellectual function, to me, is not as important. I care more about mental status. What's your thought content? Not so much how smart you are. I'm going to care about if we're talking about dogs and all of a sudden we start talking about World War II. Where does that thought, how do the two connect, right? Emotional status. Do you have emotional mobility, right? 1 second you're crying, happy. You're crying and then the next second you're happy. Weird. I mean, your language ability, how to catch your lifestyle and level of consciousness, which we'll talk about a little bit more here. Cranial nerves, motor system, what is your ability and your strength? Sensory system, do you have neuropathy? Is it fully intact? And then your reflexes, there's a nice video here of how to assess deep tendon reflexes, including your biceps, triceps, radial, radialis, patellar, Achilles, all that fun stuff. I think for your NCLEX or ATI, you need to know what these are and why they would not be happening. For me, no.
Is there like a scale that you're using when you're testing?
Usually it's a scale of like +1, +2, +3. Because deep tendon reflexes are an involuntary movement, right? That's why I take your knee and go like this. So if I just kind of go and +1, if I go +2, so if I whack you in the face, +1, that's hyperactive. So reflexes is not so much about where you are cognitively, but it's about where you are compromised. Now, sometimes people see you like doing the thing and they'll purposely like do a little bit more than it has to be, which is why sometimes providers test it while you're talking and they're distracted, so they don't actively think about what you're testing, because that's when you get a more accurate result. Emotional status too, not just much emotional ability, but what they're affective, which you guys will talk more about in a second. Oh, motor strength. We can have all here. Integrity. Alright. How many of you have seen a full neuro, well I won't say full, but like a focused neuro in the hospital setting? Few of you? What's the first thing that they test? Alert oriented. I know that's alert oriented, that's all I'm taking notes. What else? Yeah, that's more in-depth neuro. I'm just talking like you're very basic, you're getting it with your baseline. So hands up for me. What am I assessing here? Tremors and type of dress. Okay. My fingers? Hard as you can. Break up. What am I testing there? Perfect. +5. And I do basically do the same thing with their feet. I have you lift up, push down, push down, gas pedals. I do that on every single patient. I have gone into discussions with nurses about this. They say that's a focused neuro. They're not here for a neuro issue. You don't need to do it. I think that's full. Because anybody at any time can have a neurological change. And I want to know at 8:01 if Jeffrey can squeeze my fingers at +5, because at 8:02 he can, that's an issue. I personally do it on every single patient. Just that very basic strength, motor strength, neuro assessment, level of consciousness, mental status. And then if something happens later down the road, I'll do cranial nerves. That's my own personal. If you take anything out of my lectures on neuro, get your baseline. Get your basic neuro baseline. Because sometimes a neuro change is as little as they can kind of count back from 100 an hour ago and now they can't. And that's their first sign of a neuro change.
Why do you think we get a cerebral angiography? Blocks, strokes, right? I want to see how well that blood is flowing. There is a bleeding risk, right? Because we're going through an artery, so we need to make sure what? We need to make sure they're not on what?
Blood thinners.
Blood thinners. We're also injecting iodine, so what else do we need to check before? Allergies, what else?
Renal.
Renal. I want to know what their PO and creatinine is. I want to know how well they can get rid of that iodine. Fun fact, my great-grandmother died because she got some sort of test with iodine, and it did not test her PO and creatinine first when she had kidney function, and it completely killed her kidneys when she died because it didn't check PO and creatinine. CT scans. You guys know we love them. Images of the brain looking for tumors, infarctions, even if it's just a no guidance for a biopsy. The reason why we get CT scans is because brain lesions have a different tissue density than normal brain tissue, so that's why we get CT evidence. We can also see some blood vessels on a CT. EEGs are for what? Seizures. Tells us, actually, lets us see your brain waves. ICP monitoring, we'll talk about that more in depth in a minute. MRI shows us actual chemical changes within the cells, and blood flow. Why do we get a CT most of the time before we get an MRI?
It's faster.
Faster. It's faster. And what do I have to worry about with MRIs? Claustrophobia, what else? Metal. Right? So let's say somebody comes in, it's a trauma activation, whatever. I don't know if they have any metal in their body that could potentially get ripped out during the MRI. That's why we go get this, so we get more information. MRIs do produce a more detailed image than CT scans. Which is why when somebody comes in with a stroke, you do both. Because sometimes strokes won't show up on the CT scan right away, but they will on the MRI. But again, CTs are faster. And we're going to talk about CTs and strokes next. More diagnostics. You can do a PET scan. It tells us actual organ function, actual blood flow, and how the brain is metabolizing things. Because the brain consumes 80% of our glucose in our body. So we want to know, and the PET can tell us, how the brain is using that glucose. We can do a single photon, a SPECT. It captures a moment of blood flow at the time of injection of contrast. So if I just want to look at this small area, I can inject the contrast and see it right then and there how fast it's going through. Myelography is X-ray of the spine, of the subarachnoid space, after contrast is injected through the lumbar puncture. The contrast is water-based and disperses through the cerebrospinal fluid, and that's how we outline that subarachnoid space. We're looking for malformations, tumors, herniated discs, and usually we follow it up with a CT. Nerve conduction studies. Basically, if there's more velocity in the study, that means there's some sort of synaptic obstruction. And usually we do that one before we do the angiography. Not always. Obstruction. I would say the diagnostic procedures on this page are less common. Your book says that this happens before an angiography, but I haven't seen it, doesn't mean it doesn't happen. The first slide, this one, are definitely your most common ones. Alright, you guys with me so far? Alright, we're all done with this PowerPoint, and then we'll take lumbar punctures, or spinal tap. So, a sterile needle is injected into the widest intervertebral space of the lumbar subarachnoid. And that's a lot of it works. So between L2 and L3 and L4,
still a risky procedure, as much as it's done pretty frequently. Okay. So, before the procedure, we gotta get, I'm gonna educate, assess for that bleeding risk. Only their hospital gown, we need that, their entire spine open. We want them to void prior to why? You're not gonna get up for a while. And if I have a huge bladder, hey, let's say we're doing this for a pregnant person. I'm gonna shift my uterus, right? And if I have a very large bladder, I can let loose as they're putting the needle. Gross. I wouldn't want that to happen to me. And it just reduces the pressure in our abdomen when we're accessing a very sensitive area. And we want them to get involved position on their side. Now, this can be done sitting up, but it is preferred on the side. It is very uncomfortable. I was asking my sister-in-law, she had this done a couple of years ago for like worsening headaches. And she said it was probably, in compared to her epidural a few years later, she was like, it was pretty equal, but they're putting it in the same spot, but laying on my side made me more anxious than sitting up, which I thought was interesting. I do believe that because we're taking CSF out, it's better to lay down, that's why we need to get involved, versus if we're putting a medication in, it'll probably let somebody sit up. After the procedure, we want to obviously monitor the puncture site. What are we looking for? Infection, what else? Any leakage. We need to have them lay flat for several hours, which can be very long. And once they are done with their bed rest, they can go back to their normal activity. However, we can have a post-lumbar headache. There's a lot. What we can do for that, well, let me back up. Why do you think people might have a headache afterwards? Leaks. Because we're losing some fluid, right? We took some fluid out. There's not a lot of fluid in there, right? Like, what if we take out 100? That's a fifth of the fluid overall. So what can I do to help them? Hydrate. Thank you. CSF leaks. Intracranial herniation. This is a major risk if somebody already has increased ICP. If somebody has increased ICP, lumbar punctures are contraindicated because the risk is so high. But somebody can develop increased intracranial pressure after the lumbar puncture, and then it creates the herniation. We have some sort of abscess hematoma, meningitis. I might not be able to avoid a lot, right? Which is another reason why I want to avoid prior to, so I know exactly when the last time the pain was. Backache or spasms, neck stiffness. I will say neck stiffness is usually a precursor to meningitis because usually that's a sign of it. Also, it can just be that they're like this in the neck for a second. Doesn't always have to be serious. When do I not do a lumbar puncture?
Increase ICF.
Your last round on the scale. If you work in a, if you are at a clinical site with Epic, you'll see this as part of everybody's head to toe assessments. I think it should be done on every single patient. Okay? Not required, not clinical use. Because it determines your level of consciousness. It tells me how people are opening their eyes. Are you opening your eyes the second I walk in a room? Or do I have to snarl or you just need to open your eyes a little bit? Or do you not open at all? Verbal response? Am I oriented? Am I a little confused, but I'll get it if you give me some time. I'm not saying anything, like if I ask you what the president is, and you say, I went to Disney World last week, that's not an appropriate answer. You're not making any sense at all. Again, no response. And then your motor response. Do you move when I tell you to move? Or do I have to pinch you to get you to be like, ow, that hurt? And then abnormal flexion, extension, we'll talk about that kind of position later on. Again, or no response. I could literally stab you with a needle if you don't move at all. Indicates any type of head injury, space occupying lesions like brain tumors, infarctions after a stroke, encephalitis. The best score you can get is 15. 8 or less is comatose. 3 is unresponsive.
if I score less than, if I'm doing this after a head injury, if I score less than an 8, that's considered a severe head injury. 9 to 12 is moderate, more than 13 is severe. This, when I say get your baseline, this is a great baseline to get. ICP monitoring. There's a good touch on this, so we can go more in depth when we talk about ICP. But I can put scopes in right in the ventricles of the brain. Because what do you think my goal is? What am I trying to take out and monitor here? So is that CSF? Because where is CSF created? I can put it right in the subarachnoid space with a screw or a bolt. Or I can put it right in the epidural because I'm not puncturing this dura. So technically, it's considered non-invasive. I don't know how, but technically it's considered non-invasive. I will say the most common is your intraventricular and your subarachnoid. Your intraventricular, we can put one of those 3-way stop cops on. So not only can I take CSF out if I need to, I can monitor pressure at the same time. Or usually what happens is this, instead of manually taking CSF out, we hook it up to a drain, where it just actively drains while we monitor. So based on the pressure ICP, however, with gravity, we take CSF out by gravity so that the pressure comes up to where it needs to be. Does that make sense? We're gonna go more in depth about that. All right. We are going to take